Diarrhea is defined as the stool volume more than 200 grams per day, more in frequency or in consistency. Hi everybody, I am Dr. Shoukat Ali, consultant physician and diabetologist from Apollo Main Hospital, Girims Road, Chennai. Let me just talk about the incidence of diarrhea because most of the people come with the complaints of acute diarrhea or chronic diarrhea. Most of the time it is food indiscretion or infective diarrheas. Diarrhea is defined as the stool volume more than 200 grams per day, more in frequency or in consistency. It may be acute if it is within 1 week. Taken the food after 3 hours or 6 hours, you started to have diarrhea. This is called acute diarrhea. Then the chronic diarrhea is the one that lasts for 2 to 4 weeks. Acute diarrhea may be infective or inflammatory or indigestion. The chronic diarrhea is inflammatory bowel disease or chronic infections like tuberculosis, lymphomas, neoplastic diseases, lymphomas and lymphangiectasias, and fatty malabsorption in chronic pancreatitis, steatorias. These are all chronic diarrheas. Acute diarrheas, what we will have to do is first treat the fluid management because most of the acute diarrheas, they have dehydration, sunken eyes, dry skin, and high pulse, low BP, dry tongue, and the BP is very low, 60 by 40, 70 by 50, things like that. Therefore, we'll have to replenish the fluid volume first, initially, and then see for the infective agent. We'll have to give antibiotics, probably doxycycline. Then we'll have to take the investigations, stool culture, hanging drop, and then stool for GI panel. The GI panel will reveal all the infections, acute infections, enteropathogenic E. coli, enterohemorrhagic E. coli, Shigella, Salmonella, amoebic colitis, that is Entamoeba histolytica. All these organisms can cause acute diarrheas. After the fluid management, we'll have to correct the electrolyte imbalance, and then at times they might come in acute renal failure. We'll have to involve the nephrologist also because the fluid balance depending upon the urea and creatinine level and the urine output. If the kidney failure is minimal, that is urea, creatinine not more than 2, and urea not more than 50 or 60, we'll just replace the fluid and the electrolytes and no need for any nephrology intervention. When the urea creatinine has gone drastically high, when the urea is more than 80, 90 and the creatinine is more than 3 or 4, we will have to switch over to dialysis at that time because it's a temporary dialysis just to take out the urea, creatinine and all these things so the patient will improve after the dialysis. And we'll have to tell the patient this is not a permanent thing, this is just a timely intervention to keep the kidneys in balance. Nothing to worry. We'll have to console the patient regarding this thing. And then we'll have to treat the infections. Usually this acute diarrhea, if treated well, the patient's outcome will be very good. And within 3 days, 4 days, they can go home and have a normal life. But to prevent this infective diarrheas, we'll have to teach the patients of the health education, how food handling, how to deal with the food handlers, how to take clean, hygienic food, to avoid food from outside, unclosed, uncovered foods. All these things we'll have to teach as a means of health education when the patients are being discharged. Then in acute diarrheas, nothing more to add, but in chronic diarrheas, the patients will be going on having loose stools, fever and anemia, hyperproteinemia, weight loss, and all these things. That needs greater investigation. They will have to admit it and we'll have to do all the blood investigations, colonoscopies, endoscopies, and then ultrasonography to rule out any gallbladder stone and then chronic liver disease. After doing the colonoscopy, we'll have to differentiate between infective diarrhea or inflammatory diarrhea. Infective diarrhea in our part of the country, tuberculosis is the first cause because chronic diarrhea with loss of weight, loss of appetite, low-grade fever. If you do the colonoscopy, we'll be able to see the tuberculosis patches and we can take the biopsy also from that specimen. In inflammatory diarrhea, there is ulcerative colitis and Crohn's disease. There will be bleeding for rectum and then loose stools on and off. There are remissions and exacerbations in cases of inflammatory bowel diseases. Then if you do that thing, first you will have to, before doing the colonoscopy, we will do the fecal calprotectin. If the fecal calprotectin is very high, then you will have to go for endoscopy and biopsy. And biopsy will prove the thing. After taking the biopsy proven ulcerative colitis, Crohn's disease, we start the treatment, and with the treatment, the symptoms will be controlled and they can have a normal life. Then tuberculosis diarrhea, that is in chronic intestinal tuberculosis, we'll have to give the treatment for 6 months and then review the patient to see whether actually the symptoms subsided and the patient is improved in appetite, improved in weight, there is no history of fever, and there is well-being of the patient after the institution of anti-tuberculosis therapy. Therefore, we will have to review the patient once in 3 months, then once after 6 months. And then to rule out the causes that can cause chronic diarrhea, probably uncontrolled diabetes mellitus, Addison's disease, or hypercorticolism, or hypothyroidism. All these things we'll have to take into account. And we have got endocrine diarrheas like thyrotoxicosis. Thyrotoxicosis can cause diarrhea. But the thing is, cause of the problem is high thyroxine levels in the blood. Therefore, we'll have to do the thyroid function test and treat them. If you treat the hyperthyroidism, the diarrhea will stop. Therefore, we need not submit all the patients for colonoscopy. Only in selected cases, we'll do the colonoscopy and find out the cause.